The chart hit the floor before she could react. Dr. Victor Lang had swept it from her hands without breaking stride, without looking at her, without a single word of acknowledgement, just a casual, contemptuous flick of his wrist that sent blood-soaked trauma papers scattering across the polished linoleum of Silver Ridge Medical Center's trauma bay. Olivia Carter knelt and picked them up. Every page. Every one. Nobody helped her. Nobody even glanced her way. To the surgeons, the residents, the charge nurses running past, she was furniture. Background noise and scrubs. Not one of them knew what she had once commanded. Not one of them knew what was already coming toward this hospital at 200 miles an hour. They were about to find out. If this story already has you hooked, stay with me until the very end. Hit subscribe so you never miss what happens next. Leave a like if Olivia deserves justice, and drop a comment telling me what city you're watching from. I want to see exactly how far this story travels. The morning had started like every other morning at Silver Ridge. Olivia arrived at 6:45, 20 minutes before her shift technically began, because that was just how she was built. She checked the overnight board, reviewed the handoff notes from the night team, and quietly flagged 2 patients in Bay 4 and Bay 7 whose vitals had drifted in directions that nobody else had flagged yet. She left notes in both charts. She didn't make an announcement about it. She just did it and moved on. Bay 4's patient was running a low-grade fever that had ticked up 0.2 of a degree over 3 hours. Nothing that would trigger an automatic alert, but enough of a pattern that Olivia had learned in a different life, in a very different kind of operating environment, to pay attention to. Bay 7's patient had a subtle asymmetry in bilateral breath sounds that the night nurse had attributed to positioning. Olivia wasn't convinced. She flagged both. She moved on. By 7:15, the day shift was in full swing, and Dr. Victor Lang had already made his entrance. There was no other word for what Victor Lang did when he walked into a room. He didn't arrive. He didn't show up. He made an entrance. Shoulders back, chin elevated at a precise angle that communicated both authority and barely concealed boredom, the white coat immaculate, the stethoscope positioned with the studied casualness of someone who had practiced studied casualness for many years. He was 47 years old, the chief of trauma surgery at Silver Ridge Medical Center, and he moved through the hospital as though the building had been constructed specifically to serve as a backdrop for him. Morning rounds, he announced to no one and everyone, and the cluster of residents who had been waiting near the nursing station immediately fell into formation behind him, like ducks behind a particularly aggressive parent. Olivia was standing at the medication cart when he swept past. She had the blood work results for Bay 4's patient in her hand. The fever had confirmed her suspicion, white count climbing, early signs of a brewing infection that needed intervention now before it escalated, and she stepped forward. "Dr. Lang, I need to flag something on Mr. Delaney in Bay 4. His labs came back and I think—" He took the chart from her hand without slowing down, glanced at the top line. Then, with the same thoughtless efficiency with which someone might discard a piece of junk mail, he swept his arm to the side and let the papers go. They hit the floor in a cascade of white, some of them sliding 6 feet across the linoleum. "Have housekeeping clean that up," he said, to no one in particular. To one of his residents, without pausing, "I want updated imaging on the post-op in Bay 2 before I get there." And he was gone. Down the corridor, residents trailing behind him. The mild ripple of the moment already smoothed over, as if it hadn't happened at all. Olivia stood very still for exactly 2 seconds. Then she bent down and picked up every page. Margaret Osei, one of the senior nurses who had been at Silver Ridge for 11 years, appeared at her elbow and helped gather the last few sheets without comment. When Olivia straightened, Margaret's expression was carefully neutral, in the way that people's expressions become carefully neutral when they have watched the same scene play out enough times that outrage has curdled into something quieter and sadder. "Chart audit this afternoon," Margaret said quietly. "Lang wants all nursing documentation reviewed for the Caldwell complaint." "I know." Olivia reorganized the papers. "Bay 4's patient needs an infectious disease consult today. I'm going to put in the referral." "Lang didn't—" "I know." She met Margaret's eyes for a moment. "I'll document it properly. He can countermand it if he disagrees." She said it without heat. She turned back to the medication cart and continued what she'd been doing. Margaret watched her for a moment, then went back to her station. This was the texture of Olivia Carter's days at Silver Ridge Medical Center. Not dramatic, not cinematic, just a continuous grinding accumulation of small dismissals, each one individually unremarkable, collectively exhausting. She had been working at Silver Ridge for 7 months. She was 31 years old. She held a master's degree in nursing with a specialization in critical care, and she had arrived with a resume that listed 8 years of clinical experience, which was technically true, and which told approximately 3% of the actual story of who she was and what she had done. She had not filled in the rest. This had been a deliberate choice. People tended to react in complicated ways when they learned the rest. Some became deferential in ways that made her uncomfortable. Some became suspicious or competitive or challenged her constantly as if she had something to prove. She had come to Silver Ridge wanting to be a nurse. She had wanted the work without the history attached to it. She had wanted to stand in a trauma bay and help people without the weight of a different identity reshaping every interaction. She had not anticipated Dr. Victor Lang. Or more accurately, she had not anticipated quite this particular variety of institutional hostility, the kind so embedded in the hierarchy that most of the people around her had stopped seeing it at all. The morning progressed. She completed her medication rounds, assisted with a difficult IV placement that 2 other nurses had already attempted, sat with a post-surgical patient whose anxiety was spiking and talked him back down from the edge of a panic attack with the particular kind of low-key, matter-of-fact calm that she had developed in environments where panic costs lives. She ate half a granola bar standing at the nursing station at 9:40 because she hadn't had time to sit. She flagged a potential drug interaction that the attending physician had missed and sent a quiet message through the system rather than making an announcement. She was good at this. She had always been good at this. And at Silver Ridge Medical Center, being good at this and being invisible were apparently not mutually exclusive. At 10:15, the emergency alert system activated. Not the standard alert that indicated an incoming trauma or code blue. The mass casualty protocol. A sound that most of the staff at Silver Ridge had never heard activated in a real emergency, because the last time it had gone off for real was 4 years ago. A multi-vehicle accident on the highway that had sent 11 people through their doors simultaneously. What came across the radio from dispatch was clipped, professional, and hit Olivia in the chest like a physical impact. Silver Ridge Medical, this is Ravenport Emergency Coordination. We have a military aircraft down. Repeat, military aircraft down, approximately 11 miles north-northeast of the city. Initial reports indicate experimental test aircraft with crew of 5. Multiple critical casualties confirmed. Ground transport en route, ETA 18 to 22 minutes, requesting full trauma activation. The trauma bay erupted. Victor Lang's voice cut through the noise immediately, loud and commanding, already stepping into the role that crisis gave him. The role where he was most comfortable, where the authority was absolute and unquestioned, and even people who privately disliked him acknowledged that he performed well. He was not, in fairness, a bad surgeon. He was a skilled trauma surgeon with a genuine talent for operating under pressure, for making fast decisions and executing them cleanly. His problem was not competence. His problem was that his competence had insulated him from ever having to grapple with what lay beyond it. Full trauma team to Bay 1, 2, and 3. I want the OR on standby. Respiratory, get your team down here. I want blood products, O negative, staged in the trauma bays before they arrive. Go. People moved. Olivia moved with them. She was already running the math. 5 crew members. Military test aircraft. The language in the dispatch, experimental, meant unknown specifications, potential for unusual injury patterns, possible exposure to fuel types or materials not standard in commercial aviation. Crash at speed. Blunt thoracic trauma was almost guaranteed. Traumatic brain injury possible in multiple casualties. Extremity injuries, probable burn component if there was post-crash fire. She went to the supply room and pulled things that hadn't been requested yet. A needle decompression kit, chest tube trays, an emergency surgical airway kit. She set them on the crash cart in trauma bay, too, with the efficient, economical movements of someone who had done this kind of preparation in conditions considerably less favorable than a fully equipped American hospital. Margaret appeared at her elbow again, eyes wide. Lang hasn't called for those yet. I know, Olivia said. He will. She had the airway kit open and staged before Lang had finished his second round of orders across the trauma bay. She did not draw attention to it. She positioned it where it would be immediately accessible and went to take her assigned position on the team. The 18 minutes before the first ambulance arrived had a specific quality that Olivia recognized: the tight, breathless preparation of a unit about to receive incoming, the controlled chaos of people making final checks, the adrenaline that had to be managed rather than suppressed, because suppressing it entirely made you slow. She had stood in this same interior space more times than she could count, in operating theaters that had been tents, in surgical suites that had been the back of armored vehicles, in field hospitals where the equipment she had staged was not silver crash carts, but battered field kits held together with tape and institutional stubbornness. She breathed. She checked. She waited. The first ambulance backed into the bay at 10:33. The paramedics were calling out stats before the doors opened. Male, approximately 35, blunt thoracic trauma, GCS 12 on scene, dropped to 9 in transport, BP 80 over palp, tachycardic at 128. The gurney came through the doors, and Olivia had already positioned herself at the patient's left side before the attending resident reached him. She didn't push anyone out of the way. She simply moved to where she needed to be with the kind of quiet authority that didn't require announcement. She looked at the patient, not at the monitors, not at the readouts the paramedics were relaying, at the patient. The trachea was deviating slightly to the right. The left chest wall moved differently from the right on each labored breath. Subtle, the kind of thing that monitors didn't catch and that exhausted eyes could miss entirely. His neck veins were distended despite the compromised blood pressure. Tension pneumothorax. Classic presentation, slightly atypical in degree, but unmistakable once you knew what you were seeing. He needs decompression now, she said. Left side, second intercostal, mid-clavicular. The tracheal deviation is right-sided, tension pneumo. He's going to arrest if we don't decompress. The resident, Dr. Pham, second year, smart but inexperienced in mass casualty scenarios, looked at her, then at the monitors, then back at her with the particular expression of someone who wanted to defer to the person who clearly knew what they were talking about, but was acutely aware that she was a nurse and he was a physician, and the hierarchy of the situation was not straightforwardly accommodating to this moment. Lang's voice from across the bay. "What's the status on Bay 1? Nobody answered the decompression question. 3 seconds of institutional paralysis while the patient's oxygen saturation continued dropping. "Decompression," Olivia said again, calm, flat, unargumentable. She had the needle in her hand. She looked at Dr. Pham. "Right now, do you want to do it, or do you want me to talk you through it while you do?" Dr. Pham made a decision. He took the needle. "Talk me through it." She did. She guided him through it in 30 seconds of spare, precise instruction, and the rush of air as the needle entered was audible even over the noise of the trauma bay, and the patient's oxygen saturation began climbing before they had the chest tube set up. Lang appeared at the bay entrance. He looked at the patient, at the monitors, at Dr. Pham holding the decompression needle. "What's the status?" "Tension pneumo," Dr. Pham said. "Decompressed. BP is responding." He didn't mention that Olivia had identified it. He wasn't being deliberately dishonest. He was reporting to his supervisor in an active crisis, and there wasn't time for attribution. But the result stood. Lang nodded and moved on to Bay 2. The second ambulance arrived while the first patient was being stabilized. This one came in hotter. The paramedics' voices had a different quality. The controlled urgency ratcheted up. And the patient they brought was younger, early 20s, with the gray pallor shock complexion and the specific mechanical quality of chest movement that Olivia recognized immediately. Hemothorax. The left chest cavity was filling with blood. He needed a chest tube, and he needed it now. And unlike the decompression scenario, this one was unambiguous on visual assessment. The decreased breath sounds on the left, the percussion dullness that she confirmed with 2 quick taps, the blood pressure that was holding but wouldn't hold for much longer. She was already pulling the chest tube tray from the crash cart, the one she had staged before the ambulances arrived, when the resident assigned to Bay 2 was still reading the paramedics' handoff notes. "Chest tube left side," she said to the resident. "Dr. Aurelio Marsh, third year, steadier than Pham, better hands." Hemothorax, the tray's already set up. He looked at the tray. He looked at her. Something shifted in his expression. Not resentment exactly, but a recalibration, the adjustment of a person who has encountered something that doesn't fit their existing model of a situation. "You prepped this before they arrived," he said. "Yes." "How did you know we'd need it?" "Because aircraft crash, crew of 5, blunt thoracic trauma. The math said we would." She was already gloved. "Do you want to start, or should I assist?" The third ambulance arrived before the second patient had a chest tube in place, and the fourth was less than 4 minutes behind it, and the trauma bays at Silver Ridge Medical Center were running at a level of simultaneous intensity that most of the staff had never encountered in their actual careers, only in the simulation drills that always feel slightly artificial and never quite capture the specific layered weight of multiple people in genuine danger all at once. Olivia moved between bays. This was not her assigned role. She was supposed to be stationed in Bay 2, assisting Dr. Marsh. But the staffing was strained, the crisis had outpaced the initial resource deployment, and nobody was managing the overall picture clearly enough to catch what was falling through the gaps. She caught them. Bay 3, a patient with a jaw fracture and altered consciousness who needed airway protection before the swelling progressed further. She found the surgical airway kit she had pre-staged, confirmed the indication, and was already briefing the attending, a senior surgeon named Dr. Keene, who had arrived from a different department when the mass casualty alert went out, when he reached the bay. "Airways compromised," she said concise. "Mandibular fracture with swelling progressing. GCS has dropped 2 points since arrival. I'd recommend surgical airway before we lose access." Dr. Keene looked at the patient, looked at the monitors, looked at her. He was not, Olivia had noted in the 7 months she'd worked at Silver Ridge, the kind of physician who led with ego. He was 61 years old, had been in medicine for 35 years, and had the quality of someone who had long since gotten over needing to be the smartest person in the room, because he had been in enough rooms to know that the smartest person wasn't always the one with the most letters after their name. "Agreed," he said. "You've assisted on this procedure?" "Yes," she said. He didn't ask her to elaborate. "Then let's go." The fourth patient stabilized faster than anyone expected. The fifth hadn't arrived yet. There were reports of a longer extraction from the crash site, complications with access to the cockpit section. And in the temporary gap between crises, Olivia stood at the central nursing station and looked at the status board and ran the count. 3 critical patients receiving active intervention. 2 stabilized but requiring continued monitoring. The OR had been notified but hadn't been needed yet. The interventions that had been most critical had all been executable in the trauma bays, which was exactly what she had anticipated. The staff were exhausted already, the adrenaline beginning to hit the edge of the window where it shifted from useful to problematic. And somewhere in the back of her awareness, threading through everything, was the specific quality of the 5th casualty report. Longer extraction, cockpit, delay. That meant the most serious one was still coming. Lang appeared at her shoulder. He was still operating in command mode, still projecting the authority that crisis situations gave him, but there was something different in his expression now. A slight tightening around the eyes, a quality of surveillance that was less confident than his usual presentation. He had been in the trauma bays. He had seen what she had staged before the ambulances arrived. He had heard the calls she'd made. "Carter," he said. She turned. "Where are you getting your information?" The question was phrased badly. It came out sounding like an accusation, like he suspected her of something, which was probably not what he intended. Or possibly it was. With Lang, it was genuinely difficult to tell. "What information?" "The decompression call. The chest tube being staged before we needed it. Keene said you recommended the surgical airway before imaging confirmed it." "Pattern recognition," she said. "Mechanism of injury, clinical presentation, vital sign trends. It's standard trauma assessment." He stared at her for a moment with an expression that was trying to decide between irritated and impressed and hadn't landed on either. "You're a nurse," he said. The way he said it, not hostile exactly, just factual in the way that people state facts they consider self-evident and somewhat limiting, told her everything she needed to know about how this conversation was going to go. "Yes," she said. and you've had experience with this kind of mass casualty scenario." It wasn't quite a question. She let it sit for a moment. "Some," she said. He opened his mouth to say something else, and then the radio on the nursing station crackled, and the dispatch coordinator's voice came through with the update on Casualty 5, and the quality of what they said stopped the conversation entirely. "Silver Ridge, be advised. Final casualty from aircraft incident is inbound. Paramedic unit reports patient has been in cardiac arrest approximately 22 minutes. CPR in progress. ETA 4 minutes. Advise on trauma team availability." 22 minutes. The room processed this with the particular silence of people doing math they don't like the answer to. 22 minutes in cardiac arrest. That was the outer edge of viability. That was the statistical territory where most attending physicians began making the calculation about when to call it, not because they didn't want to fight, but because the brain doesn't survive without oxygen, and at 22 minutes, the question of what you're fighting for becomes genuinely complicated. Lang turned from the radio. His voice had shifted, quieter, but with a harder edge. "Get the team assembled. Bay 1. People moved. Olivia moved with them. She was already calculating what they were going to need and what they were going to find, and underneath the calculations, beneath the clinical assessment and the protocol review and the rapid inventory of available resources, there was something else running. The particular focused attention that she had learned to access in the worst moments of a very different career, the quality of presence that other people had sometimes called extraordinary, and that she had always thought of simply as the minimum required. She did not think about what it would mean if this patient died. She thought about what it would take to keep him alive. The ambulance backed into the bay 4 minutes later, and the team around Olivia closed in, and somewhere north of the city, still at the crash site, the last report was filtering in through military channels that Silver Ridge Medical Center was not monitoring, but that several people already en route to the hospital were. The doors opened. The gurney came through. The paramedic leading it was speaking, and his voice had the flat, contained quality of someone maintaining professionalism over something that was costing him a great deal to contain. Male, late 30s, ejected on impact, found in cardiac arrest, CPR initiated at scene, 26 minutes ago now. No ROSC. We never got him back. 26 minutes. Dr. Lang stepped forward, and Olivia Carter looked at the patient on the gurney, looked at him with the full weight of everything she was and everything she had done and everything she had spent the last 7 months trying to set aside, and understood something that she was not yet ready to say out loud. She was not going to let this one go. The paramedic's words hung in the air for exactly 1 second before Olivia moved, not toward the monitors, not toward the crash cart, toward the patient himself, was close enough to see what the numbers couldn't tell her, what the equipment hadn't registered yet, what 26 minutes of CPR in the back of an ambulance on rough terrain might have obscured from everyone who had been focused on keeping the mechanics of resuscitation going rather than looking for the reason they weren't working. She put her hands on him, jaw, neck, chest. She was listening with her fingers as much as her eyes, and what she felt in the first 4 seconds confirmed something she hadn't said yet because she needed to be certain before she said it. "Keep compressions going," she said to the paramedic who was mid-handoff, about to step back. "Don't stop." He looked at Lang. Lang gave a curt nod, and the paramedic resumed. Olivia pressed 2 fingers along the left sternal border, then the right. Then she placed her palm flat against the patient's interior chest and held it there while the room watched her with the complicated expression of people observing something they couldn't quite categorize. "He has a tamponade," she said. Silence. The kind that has weight. Dr. Lang crossed the bay in 3 steps. "What?" "Cardiac tamponade." She kept her voice level. The flat certainty of it was not performance. She simply didn't have room in this moment for anything other than accuracy. "The pericardial sac is filling with blood. That's why CPR isn't getting ROSC. You can pump all day and you won't circulate effectively if the heart can't fill between compressions. He needs a pericardiocentesis." Lang stared at her, then at the patient, then at the resident beside him, Dr. Pham, who had been assigned to Bay 1 and was standing at the ultrasound machine with his hand on the probe but hadn't yet applied it. "Get echo on him," Lang said sharply. "We don't have time for—" Olivia started. Get the ultrasound on him, Lang repeated, louder. She stopped. She understood what he was doing. Not being obstructionist, not dismissing her specifically, but following a protocol that existed for good reasons, that had been written to prevent the very real danger of a clinician acting on an incorrect assessment. She understood all of that. She also understood that the ultrasound would take between 90 seconds and 3 minutes to set up, interpret, and act on, and that the patient had been without effective circulation for 27 minutes now, and that every 30 seconds at this stage was not a statistic, but a specific, irreversible portion of a human brain. She moved to the ultrasound cart and helped Dr. Pham position the probe. Her hands were faster than his. She didn't take over. She guided, 2 fingers adjusting the angle, the pressure, the window. And the image that came up on the screen was unambiguous. A bright white ring of fluid surrounding the heart. The right ventricle compressed, collapsing inward with each ineffective beat. The pericardial effusion was significant, large enough that it should have been caught on assessment, would have been caught if they'd had more time, more resources, if this had been a single patient in a calm environment instead of the 5th casualty in a mass event, with every available clinician already stretched to capacity. There, Olivia said. Lang looked at the screen. 1 second. 2. Pericardiocentesis kit, he said. Now. It was already in her hands. She had pulled it from the crash cart 40 seconds ago, before the ultrasound was even fully positioned, because she had been certain, and she had staged it at the edge of the tray where it would be accessible without getting in anyone's way, the same way she had staged everything else that morning. The same instinct that nobody in this room had thought to ask about yet. Lang took the kit from her without comment and moved to the patient's left side. His hands were good. Whatever she thought of him personally, however many times she had watched him walk past her like she was part of the wall, she had never had any doubt that his surgical hands were precise and well-trained and capable of exactly this. He found the subxiphoid angle and worked with the focused efficiency of someone who had performed this procedure enough times that his body knew the steps before his mind consciously directed them. The needle went in. Dark blood flowed back into the syringe. "Keep compressions," Olivia said to Dr. Pham, who had taken over from the paramedic. 20 milliliters. 40. The monitor above them showed the flat line of CPR artifact, the up-down mechanical regularity of external compressions, and then, at 60 milliliters of blood drained from the pericardial sac, something changed. Not a dramatic change. Not the movie version. A small, irregular electrical signature appearing between the compression artifacts on the ECG trace. Disorganized. But there. "Hold compressions," Lang said. The room held its breath. The ECG line stuttered, wandered, threw out 3 chaotic beats that weren't quite anything. Not V-fib, not sinus, not the organized electrical chaos of a heart trying to remember what it was supposed to do and not quite getting there yet. Then it found something. A narrow complex. Then another. Then a third that came at the right interval, and a fourth. And the line began to organize itself into a rhythm that was weak and irregular and had a rate of only 42 beats per minute, but was unambiguously, definitively, a rhythm. "We have electrical activity," Dr. Pham said, his voice cracking slightly on the last word. Olivia was already at the medication drawer. "He needs atropine and we need to be ready to pace. Rate's too low." She pulled the atropine and had it in the resident's hand before Lang turned around from the patient. 0.5 milligrams to start. If we don't get rate response in 2 minutes, we go to external pacing. Lang turned around and looked at her with the syringe in his hand, the syringe she had put there. And for a moment there was something in his expression that she hadn't seen before from him. It wasn't quite recognition. It was more like the beginning of a question he didn't yet know how to form. "Do it," he said. The atropine went in. The rate climbed, slowly, stubbornly, through the 40s and into the 50s, and then, at 1 minute and 40 seconds post-administration, it crossed 60, and the blood pressure cuff that Dr. Pham had already applied began reading something. "BP is 62/40, Pham said. "Low, but it's there. It's reading." The room exhaled. Not all at once, not with any ceremony, but the specific quality of the air changed. The compressed tension of people who had been holding everything tight, releasing a fraction of a degree. Olivia was already thinking 3 steps forward. "He needs the OR," she said. The tamponade is drained, but the source is still bleeding. He's going to reaccumulate unless we get him into surgery and control the bleeder. How long to have an OR room ready? The OR charge nurse, a woman named Delphine Ruiz, who had been standing at the bay entrance receiving updates, answered before Lang could. Room 3 is being turned over now. 8 minutes. He may not have 8 minutes if the reaccumulation rate is fast. Olivia looked at the ultrasound screen where the image was still displayed. The ring of fluid around the heart was thinner now, but not gone. We need to move him now and have the room ready when we arrive, not wait here until the room is ready. Lang looked at Delphine. Something passed between them, the rapid, wordless calculation of people who had worked together long enough to read each other's operational assessments. "Get room 3 ready," Lang said. "We're moving in 5. He said it like it was his decision, which technically it was. Olivia didn't argue the point. The patient's blood pressure was climbing slightly, 68/44 now, and she was watching the ECG for any sign of rhythm deterioration, for the specific pattern that would indicate the tamponade was reaccumulating faster than she'd hoped. She was watching so carefully that she almost missed the moment when Dr. Pham looked at her across the gurney with an expression that was somewhere between bewildered and awed. "How did you know?" he said quietly, under the noise of the room being reorganized for transport. She looked at him. He was 26, maybe 27, still in the phase of his training where the gap between what he knew and what experienced clinicians could see felt infinite and slightly terrifying. "Pattern," she said. "You'll see it enough times, it starts to look obvious. 30 years from now, maybe." "Sooner than that," she said, "if you pay attention to the right things." She didn't elaborate on what the right things were. She turned back to the patient and checked his airway, his IV access, the positioning of everything that would need to travel with him to the OR, and the conversation closed. They moved him to the OR at 10:57. The trauma bays without the 5th patient were still not quiet. The first 4 casualties were all in various stages of active management, and the staff who remained were still running at a pace that would have been unsustainable if the adrenaline hadn't still been carrying most of them. But there was a quality of reorganization happening, a settling of the chaos into something more manageable, the difference between a fire that is actively spreading and one that has been contained to a known perimeter. Olivia remained in the trauma bays. She went to Bay 1 and checked on the first patient, the tension pneumo, now with a properly placed chest tube draining well, oxygenation stable, blood pressure recovering. She reviewed his medication orders, noted a potassium level that had come back low on the repeat labs, and put in an order for replacement. She moved to Bay 2. The hemothorax patient was being monitored closely, chest tube in place, and draining what appeared to be a controlled amount, serial hemoglobins ordered, the attending physician satisfied with the trajectory. Bay 3. The surgical airway patient. She stood at his bedside for a moment longer than the others, looking at the monitors, looking at him, a young man, early 20s, the thin frame of someone who spent most of their working life in a cockpit. A test pilot's lean efficiency carried even into unconsciousness. She thought about what it took to get into that seat. The years of training, the evaluations, the specific combination of skill and composure and physical capability that the military's flight programs demanded. She knew something about those programs. She had worked alongside people who had gone through them. She had patched several of them back together under considerably less favorable conditions than the ones she had available to her today. She adjusted his positioning by 2 degrees and went back to the nursing station. It was there, standing at the central station reviewing orders, that she became aware of the conversation happening around the corner from her. Not a private conversation. Victor Lang's voice was never quite private. It carried with the unself-conscious volume of someone who had spent a career being listened to, but a conversation clearly not intended for her. Lang was talking to Dr. Keene, the senior surgeon who had handled Bay 3. "Clearly has some field experience," Lang was saying. "She's not just a floor nurse, but there's a question of scope here. She was making calls that weren't within her documented authority." "The calls were right," Keene said. His voice was drier, harder to read. "That's not the point. The point is a nurse making independent clinical judgments in an active mass casualty without clearing them through attending." "She cleared them through me," Keene said. "I was the attending in Bay 3. She presented her assessment, and I agreed with it. A pause. And the tamponade call, Lang said. It was not quite an accusation, but it was in the neighborhood. The tamponade call was correct, Keene said. I'd want to know where she developed that level of clinical instinct, but I'd be a fool to complain about having it in the room today. Lang's response was lower. She lost the words. Olivia stood at the nursing station and looked at the orders on the screen in front of her and processed, without allowing it to change anything visible in her expression, the information that Victor Lang was already building the framework of a complaint. Not about the outcomes. The outcomes were irrefutable, but about the process, about the appropriate channels and the documentation of authority and the chain of clinical decision-making as it was supposed to flow in an institution like this one. He was not entirely wrong, technically. That was the part that required some acknowledgement. She had pushed past her documented clinical authority multiple times in the past 2 hours. She had made calls that in a non-emergency environment required physician sign-off before action. She had pre-staged equipment based on personal assessment. She had told residents what to do in language that was not quite recommendation and not quite instruction, but existed in the ambiguous territory between them. All of it had been correct. All of it had contributed to outcomes that were better than they would have been otherwise. And none of that would protect her if Lang decided to make it a formal matter, because institutions ran on documentation and process and the clearly defined boundaries of who was authorized to do what. And those boundaries existed for reasons that she respected, even when they occasionally needed to be broken. She was thinking about this in the abstract, measured way she thought about most problems. Not panicked, not even particularly worried, but attentive to the situation's real shape, when Margaret appeared at her shoulder and said, quietly and without preamble, Lang is talking to HR right now. Someone told me. I don't know what he's saying exactly, but I know, Olivia said. Margaret looked at her. You know? I heard enough. Olivia. Margaret's voice dropped. There was something in it that went beyond professional concern, something closer to the particular helplessness of someone who had watched an unfair system function unfairly too many times to have much faith in confronting it. If he files something formal, then I'll respond to it formally. It's not that simple. He's the chief of trauma surgery. When he files something, it tends to go a certain way. I know how it tends to go, Olivia said. She said it without bitterness. That was the part that seemed to unsettle Margaret slightly. Not the resignation of someone who had given up, but the steadiness of someone who was operating from a place that Margaret didn't yet understand and couldn't quite identify. Olivia went back to work, because that was what she did. The crisis wasn't over. It was entering a different phase, the phase where the acute emergency had been managed and the work became the slower, more demanding labor of maintaining the stability that had been fought for, watching for the complications that had a habit of arriving without announcement in the 12 to 24 hours after a major trauma event. She checked the chest tube drainage every 30 minutes. She monitored the repeat labs with the careful attention of someone who was not willing to let a number drift without noticing. She talked to the family members who had begun arriving in the waiting room. A mother, pale and rigid with controlled terror. A wife with 2 small children who kept asking questions the wife couldn't answer. And she spoke to them with the direct, compassionate honesty of someone who understood that false reassurance was its own kind of cruelty. Your husband's heart stopped, she told the wife, a woman named Dara, who had driven 90 minutes from the base where her husband was stationed, 2 children in the back seat, arriving without knowing whether the call she'd received meant she still had a husband or not. It stopped, and we brought him back, and he is in surgery right now with a team working to repair the damage. That's the truth. I won't tell you there's nothing to worry about, because there is. But he is alive right now, and that wasn't certain 2 hours ago. Dara looked at her for a long moment. Her hands were clasped in her lap with a tension that was almost violent. Is he going to be okay? I don't know, Olivia said, but the people in that OR are good, and we got him there. It was not the answer Dara had been hoping for. It was the only true answer Olivia had. She stayed with her for another 5 minutes, not saying much, not performing comfort, just being present in the way that sometimes mattered more than any specific thing a person could say. And then she returned to the floor. It was 2:40 in the afternoon when Lang found her again. She was in the supply room, restocking what had been used, doing the unglamorous administrative work that kept a trauma unit functional, when she heard the door and turned around. Lang stood in the doorway. He had removed his OR gown. He had gone in with the fifth patient and apparently just come out. And he looked like someone who had been running very hard for a very long time and had arrived somewhere that he hadn't expected to be. "He's stable," Lang said. "OR went well. The source bleed was controlled. If the bleeding continues to stop and there are no complications, he has a real shot." "Good," she said. Lang was quiet for a moment. He was looking at her with that same expression from earlier, the one that was trying to formulate a question and hadn't quite gotten there. "I've been in trauma surgery for 18 years, he said. "The tamponade call, even knowing the mechanism, even with 26 minutes of failed CPR as context, that's not a standard nursing assessment. That's a clinical instinct that takes a very specific kind of experience to develop." Olivia placed the last supply box on the shelf. She turned around fully. "You want to know where I got the experience?" she said. "I want to understand what I'm actually working with," he said. It was for Lang a remarkably straightforward statement. Not an apology, not a concession, but genuinely different from his usual register. She looked at him for a moment. She had kept this particular piece of information close for 7 months, for reasons that made sense to her, and that she had not felt compelled to revisit. But she also understood that the moment she was standing in had a specific gravity, that the morning's events had changed something in the landscape of this hospital, and specifically in whatever dynamic existed between her and Victor Lang, and that the version of things that had existed at 6:45 this morning no longer quite applied. "Before Silver Ridge," she said, "I spent 8 years as a medical officer in the military. The last 4 of those years, I led a forward surgical team operating in active combat zones." She kept her voice flat and factual, because that was the only register in which she could discuss it without it sounding like something she was using to impress him, which she was not. "I've run mass casualty scenarios with a fraction of the equipment and staff that we had today. I've performed field amputations, emergency thoracotomies, battlefield surgical airways in conditions that would—" She stopped. "The point is, I've seen a lot of tamponades." Lang was very still. "Why are you here?" he said. Not rudely, genuinely. "With that background, why are you here as a floor nurse?" "Because I wanted to be a nurse," she said. "I wanted to do the work. Not the rank, not the history, just the work." Another silence. This one had a different texture. "I filed a preliminary report with HR this morning," Lang said, "about the scope of practice concerns." "I know." "I'm going to need to revisit that," he said. It was the closest to an acknowledgement that she was likely to get from him today, and she understood that. It was not enough in the larger sense. It didn't address the 7 months that had preceded today. It didn't address the chart he had swept from her hands that morning as if she were irrelevant. But it was real, and she recognized it as such. "Revisit it however you need to," she said. She picked up the empty supply box and moved past him toward the door. And then she stopped, because there was one more thing to say, and she said it the same way she said everything, without drama, without the weight of 7 months of accumulated frustration loading it down, just the plain truth of it. "Bay 4 patient, Mr. Delaney, I flagged a potential infection this morning before the mass casualty alert came in. I don't know if it got lost in everything that happened today, but it needs to be actioned." Lang looked at her. "I'll check the chart." "Thank you," she said, and walked out. She was at the nursing station for 17 minutes before the next thing happened, and the next thing, when it came from outside the hospital, from the parking structure, from a convoy of 3 black vehicles with government plates that had been parked there for 40 minutes, while their occupants waited for the appropriate moment to make their presence known. The appropriate moment, apparently, was 3:14 in the afternoon on a Tuesday in Ravenport, when the trauma bay was settling into the sustained vigilance of post-crisis management, and the staff were beginning to think about the debrief that would need to happen, and the reports that would need to be filed, and the particular bone-deep exhaustion that follows a mass casualty event. Margaret saw them first. She said nothing, just stood very still at the nursing station with her hands flat on the desk and her eyes tracking something past Olivia's shoulder. And Olivia turned. 3 people in military uniform walked through the ER entrance, not the orderly of the first 2. They were clearly staff, moving with purpose, but in civilian support mode. The third one was different. She was in her early 60s, upright in the specific way that decades of military bearing builds into the body at a cellular level, her uniform bearing the insignia of a rear admiral. She walked through the ER with the measured authority of someone who was accustomed to rooms reorganizing themselves around her arrival, who had entered enough rooms to no longer notice the way people stepped back, but who had also been in enough genuine crises to know the difference between a room that is reorganizing out of deference and a room that is genuinely urgent. She scanned the trauma bay. Her gaze moved over the attending physicians, over the charge nurse, over Victor Lang, who had emerged from the supply room hallway and was now standing near the nursing station with an expression of careful professional readiness. And then her gaze found Olivia Carter, standing at the nursing station in scrubs with a patient chart in her hands, and stopped. The rear admiral walked across the trauma bay floor. She walked past Victor Lang. She walked past the charge nurse and the residents and the attending physicians and the hospital administrator who had arrived sometime in the last hour and was standing near the entrance to the administrative corridor with a visitor badge and the specific expression of someone who was managing upward in real time. She stopped in front of Olivia. The room had gone very still. "Commander Carter," she said. Olivia lowered the chart slowly. She looked at the woman in front of her, at the face she recognized, at the insignia she recognized, at the steady, direct quality of a gaze that she had encountered in very different circumstances in very different parts of the world. The chart in her hand felt suddenly very light, as if the last 7 months of holding everything she was in this single small object had abruptly shifted in weight. "Admiral Grant," she said. Rear Admiral Evelyn Grant, the woman who had overseen the military medical operations in 3 separate theaters, the woman who had signed off on more of Olivia's operational reports than either of them could probably count. The woman who had, 5 years ago, stood in front of a different kind of room and said things about Olivia's service that Olivia had spent considerable effort since then trying not to think about too directly. "I heard what you did today," Admiral Grant said. It was not a preamble, it was just the fact of it, delivered in the direct way of someone who did not traffic in preambles. "There was a team," Olivia said. "I was part of it. I've talked to the paramedics. I've talked to the OR team." The Admiral's voice was level. "I know what happened in this building today. I know what my personnel's survival looks like because you were in this room." The room was not breathing. Victor Lang, standing 6 feet away with his hands folded in front of him, was looking at Olivia Carter with an expression that Olivia did not see, because she was not looking at him. She was looking at Admiral Grant and trying to manage the very specific, complicated feeling of having the part of herself she had set down being picked back up in a room full of people she had spent 7 months being invisible to. It was not triumphant. It was not the clean, satisfying reversal that the moment might have appeared to be from the outside. It was, in a way she couldn't easily articulate, the most complicated thing that had happened to her all day. And then the Admiral reached into the inside pocket of her uniform jacket, withdrew a folded document, and held it out. "I need you to read this," she said. "We have some things to discuss." Olivia took the document. She unfolded it. She read the first 2 lines and something changed in her face. Not dramatically, not the way it would change in a film, but the small, precise way that things change in the faces of people who are processing something significant and doing it mostly on the inside. She looked up at Admiral Grant. "When did this happen?" she said. "The investigation closed 6 weeks ago," the Admiral said. "We've been trying to reach you." "I changed my contact information when I left," Olivia said. "I know." A pause that contained, Olivia thought, something that might have been the Admiral's version of an apology for taking this long, compressed into 2 words and a look. "We know." Victor Lang had taken 1 step forward, not intrusively, just the half step of a person who has registered that something important is happening and whose authority instincts are warring with his social ones. "Is there something I can—" he started. "No," Admiral Grant said, not rudely, just with the finality of someone used to closing conversations. She looked at Olivia. "I'll need an hour of your time, when you're done with your shift." "I'm done now," Olivia said. It wasn't a decision she made so much as something she simply stated, because it was true. Her shift had technically ended 40 minutes ago, and the crisis management phase was now staffed, and she had been staying because she always stayed, Because leaving felt like abandonment, even when it wasn't, even when the patients were stable and the team was capable and there was nothing specific that required her presence. Old habits. Then now, the Admiral said. Olivia looked at the document in her hands once more. Then she folded it carefully and held it at her side, and she looked around the trauma bay, at Margaret, who was watching her with wide eyes and an expression she had never worn before in Olivia's direction, at Dr. Fum, who was standing near Bay 2 with the arrested posture of someone who has just realized they may have dramatically misunderstood a situation, at Victor Lang, who was standing with his hands still folded in front of him and his expression doing several complicated things simultaneously. She picked up the patient chart from the nursing station, completed the entry she had been in the middle of, and set it back down in the precisely correct position. Then she walked out of the trauma bay with Admiral Evelyn Grant. She did not look back, but she heard in the particular quality of the silence she left behind her that the room was doing something she hadn't heard from it in 7 months. It was finally paying attention. In the administrative corridor outside the ER, away from the monitors and the controlled chaos, and the staff who were still processing what they had just witnessed, Admiral Grant turned to her and said something that was not quite what she had been expecting. Not the formal debrief she had anticipated, not the official language of the document still folded in her hand. "They sent 5 crew members into that building today," the Admiral said quietly. "I was told we'd likely lose 2 or 3 of them. We lost none." Olivia said nothing. "You know what the difference was," the Admiral said. "Good team," Olivia said. Grant looked at her with the expression of someone who has long since made peace with not arguing certain points. "Read the rest of the document," she said. "Page 3 especially." Olivia thought about page 3 as they walked toward the administrative suite where the conversation would happen, toward whatever the document contained that the Admiral thought needed particular attention, toward the version of the next hour that she did not yet know the shape of. Behind her, in the trauma bay, she was not there to see Victor Lang pick up the patient chart she had just completed and read the entry. Read it with the careful attention of someone who was, for the first time, genuinely trying to understand what he was looking at. And she was not there to see him set it back down and stand very still for a long moment, alone, with the specific quality of a man who is beginning to understand the size of a mistake. But somewhere in the administrative corridor, as she walked beside a rear admiral toward a conversation that was going to change something, Olivia Carter felt the particular quiet shift of a weight that had been pressing on her for 7 months, beginning, very slightly, to ease. Not gone, but different. She opened the document to page 3. Page 3 was a single paragraph. It was written in the compressed, precise language of military administrative documentation. No excess, no flourish, just the bare architecture of fact. And it said, in 37 words, that a formal inquiry conducted by the Joint Medical Command Review Board had concluded that the circumstances surrounding Commander Olivia Carter's separation from active duty 18 months ago had been based on falsified performance documentation submitted by a superior officer. She read it twice, not because she didn't understand it the first time, because she needed the second pass to let the specific shape of it settle, the official confirmation of something she had known was true and had spent 18 months carrying without any institutional acknowledgement that it was true, which were 2 very different weights. "Lieutenant Colonel Harmon," she said. It wasn't a question. "Yes," Admiral Grant said. They were sitting across from each other in a small conference room off the administrative corridor. Not an executive suite, just a functional room with a table and 6 chairs and a window that looked out onto the hospital's parking structure. 2 of the Admiral's staff were stationed outside the door. The room had the particular quality of temporary spaces occupied by people with serious business, stripped of the usual softening details. "The inquiry took 8 months, Grant said. Harmon attempted to suppress the communications records. He didn't succeed, but it delayed the process significantly." 8 months, Olivia said. "He had allies in the records office. It took time to establish the full scope." She set the document on the table. She looked at the window. Outside, one of the black vehicles was still parked at the edge of the lot, and she could see 2 of the military personnel who had arrived with the Admiral standing near it, shoulders squared against the cold. "What happened to him?" she said. "Harmon was formally censured, reduced in grade, and removed from command 6 weeks ago. His actions constitute a violation of the UCMJ, and the case has been referred for further proceedings. Grant paused. He will not hold a position of authority over medical personnel again. Olivia absorbed this. The feeling it produced was not what she might have predicted. Not satisfaction exactly, not relief in any clean sense, but something more complicated and less comfortable than either of those. The 8 months of inquiry. The 18 months before that carrying the falsified record. The decision to leave the military entirely rather than fight a process that had seemed, at the time, comprehensively rigged against her. The decision to come to Silver Ridge Medical Center as a floor nurse and set everything else down. The reinstatement offer on page 4, Grant said carefully. Olivia looked down at the document. She hadn't gotten to page 4. She turned to it. Read it. Her expression didn't change in any dramatic way, but something shifted in the set of her jaw. The specific quality of someone encountering a choice that is larger than the moment they're sitting in. You don't have to decide now, Grant said. The offer has a 90-day response window. I know. She set the document down again. Why did you come personally? Grant was quiet for a moment. In 18 years of military service, Olivia had found that Admiral Grant's silences usually contained something real. Not performance, not strategic positioning, but actual thinking happening in real time. Because I should have come sooner, Grant said finally. When the inquiry opened, when the initial findings indicated what Harmon had done. She met Olivia's eyes directly. I was managing 3 simultaneous personnel crises, and I delegated your case to the process, and the process took 8 months. That was a failure of leadership on my part. Not the process. Me. It was, Olivia thought, probably the most direct acknowledgement of fault she had ever heard from a flag officer. She didn't know entirely what to do with it. I left, Olivia said. That was my decision. Made on the basis of falsified information, Grant said. Made on the basis of what I could see at the time. She picked up the document again, turned it over in her hands. I don't entirely regret it. Yet Grant's expression shifted. Not surprise, but recalibration. No? I've been a nurse for 7 months, Olivia said. The work is different than I expected. She paused. Not lesser, just different. A silence settled between them that was not uncomfortable. The silence of 2 people who had operated in close professional proximity for years, and who had the history to sit quietly without it requiring management. It was broken by a knock at the conference room door. One of Grant's staff members opened it. The hospital administrator, a compact, efficiently dressed man named Mr. Holloway, whom Olivia had seen at a distance several times and interacted with directly never, stood in the doorway with the expression of someone who was very carefully managing the fact that his hospital had just been entered by a rear admiral without advance notice. I apologize for interrupting, he said, in the tone of someone who is not entirely sorry but understands that claiming otherwise is the correct institutional posture. Admiral Grant, I wanted to introduce myself. I'm Gerald Holloway, Chief Operating Officer of Silver Ridge Medical. Mr. Holloway, Grant said. I'll need 30 minutes of your time before I leave this afternoon. Of course. His eyes moved to Olivia. Something in them was doing quick, visible recalculation. Nurse Carter, I wasn't aware that you and the Admiral were acquainted, Olivia said. Yes. He looked between them. I've been reviewing the incident reports from today's mass casualty event. I understand there are some... He paused, choosing his word with the care of someone navigating a field they've been told contains mines. Process questions that have been raised. There are, Grant said. I'd like to discuss them, along with several other items. Her voice was even, professional, and carried the specific quality of someone who intended to have a very particular kind of conversation and was simply arranging the logistics. 30 minutes, this afternoon. Holloway recognized a closed door. Of course, he said again and withdrew. When the door shut, Olivia looked at the Admiral. You're going to talk to the board. I'm going to talk to the COO, Grant said. What he does with the information is his business. The preliminary HR report, I'm aware of it. Grant's expression was neutral, but not uninformed. Lang filed it at 11:40 this morning. The duty officer flagged it when my staff made inquiries about the incident. She folded her hands on the table. The 5 military personnel who came through this ER today are my responsibility. What saved their lives is my direct interest." Olivia was quiet for a moment. She was running a calculation that had nothing to do with clinical medicine. The calculation of someone trying to assess where the lines were, what was hers to manage, and what was already in motion without her. "I don't need you to fix it," she said. "I'm not fixing anything," Grant said. "I'm providing accurate information to people who are making decisions with incomplete data. That's a different thing." It was, Olivia conceded internally, a distinction with some real weight to it. She stood, picked up the document, folded it back along its original creases. "I need to go back to my patients," she said. Grant looked up at her. Something in the look acknowledged a dozen things neither of them was going to say. "Read page 4 again tonight," she said, "when you're not running on adrenaline." "I will," Olivia said. She walked back into the hospital. The trauma bay had changed in the 45 minutes she'd been gone. Changed in the particular way that spaces change after a crisis. Not empty, not calm exactly, but operating in a different register. The white heat intensity of the mass casualty response now banked down into the sustained, focused vigilance of ongoing critical care. The monitors were consistent. The labs were being reviewed. The OR had called down twice with updates on the 5th patient. Still in surgery, proceeding well, no unexpected complications. Olivia moved through the space and felt the eyes on her in a way she hadn't felt them before. Not the incurious, habitual non-attention of the past 7 months. Something different. Margaret was watching her from the station with an expression that was trying to ask 6 questions simultaneously and wasn't sure which one to lead with. Dr. Pham had positioned himself near Bay 1 in a way that was almost certainly not coincidental. She ignored both of them, not unkindly, and checked the Bay 1 patient's drainage output first. "It slowed," Dr. Pham said, appearing at her elbow. He was referring to the chest tube. He had the quality of someone who was talking about the patient because he needed a moment to organize what he actually wanted to say. "Good," she said. "How's his pressure running?" "Stable. 94 systolic. They're talking about stepping down to a step-down unit tonight if the next set of vitals hold. Watch the repeat hemoglobin before they move him. If it drops more than 2 points from the last draw, I want to know." "You're not going to be—" He stopped. "I'm on tomorrow," she said. He nodded, still hovering. She looked at him directly. "Just say it," she said. He took a breath. "Commander Carter, that was your rank." "It was." "And the Admiral, she knew you from—" "We served together," Olivia said. Simple, accurate, the minimum required. Pham looked at the patient in Bay 1 for a moment, as if reorganizing something. "The tamponade call. The pre-staged equipment. The airway in Bay 3, he said, each one like he was putting items on a list he'd been keeping. "You knew what you were doing. You knew it at a level that—" He stopped again. "A level that made you uncomfortable?" she said. "A level that I didn't understand," he said. "I thought—" He had the specific discomfort of someone about to admit something they're not proud of. "I thought you were being aggressive, overstepping, when you told me to do the decompression. I almost—" "But you didn't," she said, "because you were right." "Don't make it about being right," she said, and she said it with enough directness that he blinked. "I'm not always right. I was right today because I had information and experience that the situation made relevant. Tomorrow it might be you with the information I don't have. The point is the patient, not who made the call." He looked at her, processing. "That's a harder thing to learn than the decompression technique," she said. "Yes," he said, "it is." She moved on. Bay 2, then 3, then a full sweep of the monitoring data on all 5 patients. The 4th casualty, the one they had received while she was still managing Bay 3, had been the most straightforward of the group clinically and was now the most stable, which was a satisfying kind of irony. The 3rd patient, the surgical airway case, was beginning to show signs of improving consciousness, the GCS ticking up in the small increments that indicated the brain was reasserting itself, that the crisis had been stopped before the damage became permanent. She was reviewing his latest labs when Victor Lang appeared. He didn't announce himself. He stood 3 feet away from her until she became aware of him. The way you become aware of someone who is trying to determine the right way to enter a conversation, the the particular quality of restrained motion. She lowered the tablet. The preliminary HR report, he said. I spoke to Holloway 20 minutes ago. I've withdrawn it. She looked at him. Okay. That's all? He seemed briefly to expect something different, maybe more. What else would there be? She said. He was quiet for a moment. Lang's silences had a different quality from Grant's. Where Grant's silences contained active thought, Lang's contained active discomfort, the specific discomfort of a man in whom a particular kind of self-image was undergoing revision. I was told, he said slowly, that the Admiral is meeting with Holloway this afternoon regarding today's events. Yes. And that the meeting will include discussion of the clinical decisions made during the mass casualty response. I believe so. He looked at the tablet in her hands, at the chart, at her. Is there anything I should prepare for? And there it was. The question beneath the question, not quite an apology, not quite accountability, but the request for a lifeline from the person he had spent 7 months treating as invisible. Olivia considered it. She was not a person who trafficked in cruelty, and she had never derived satisfaction from watching powerful people reduced. But she was also not a person who pretended things were different from how they were, and something in her held on to the precise, factual reality of this morning. The chart hitting the floor, the 11 seconds she had spent on her knees gathering papers while the department moved around her, the preliminary HR report filed at 11:40 while she was trying to keep a patient from dying. Tell them the truth, she said. About today. All of it. And before today? He said. He met her eyes when he said it. That part was new. That's your story to tell, she said. Not mine. She turned back to the chart. He stood there for another moment. She heard him exhale, not quite a sigh, more the sound of a man redistributing weight, and then he walked away. The afternoon continued. The OR called at 4:22 with final status on the 5th patient. Surgery completed, source bleed ligated, pericardial repair performed, patient transferred to the cardiac ICU with a prognosis that the surgeon described as cautiously optimistic, which in this case is extraordinary. Olivia received this information standing at the nursing station and wrote it into the crisis log with the same handwriting she used for everything, which was small and precise and had no flourishes. Margaret appeared beside her. He's going to be okay, she said. Meaning the 5th patient, meaning the one who had been in cardiac arrest for 26 minutes. Looks like it, Olivia said. Because of you. Because of the whole team. Olivia. Margaret's voice had the quality it sometimes got, the quality that pushed past professional register into something more direct. Will you just, for 1 second, let it be something? Let today be something. Olivia looked up from the log. Margaret was watching her with an expression that was not entirely about the 5th patient, or the crisis, or the military convoy that had walked through the ER 4 hours ago. It was the expression of someone who had watched a person work beside them for 7 months, and had gradually understood, in the accumulation of small moments, that they were standing next to something they hadn't recognized. It is something, Olivia said. Then act like it. She almost smiled. Almost. She completed the entry. She was reaching for the next chart when the doors at the far end of the trauma bay opened and Gerald Holloway walked in, moving with more purpose than she had previously observed in him. He was followed by a woman she didn't recognize, middle 50s, carrying a tablet, wearing the specific expression of someone whose job involves delivering information and who has learned to keep her own reaction out of her face while she does it. Behind them, a step back, was Victor Lang. Holloway crossed the bay with the particular directness of someone who has had a conversation that changed their understanding of a situation and is now acting on the new understanding. He stopped in front of Olivia. Ms. Carter, he said, I've just concluded a meeting with Admiral Grant. I'd like to speak with you in my office. Now? She said. If you're available? She looked at the trauma bay, at the monitors, at Dr. Pham, who had registered the gathering and was watching from Bay 1 with his hand still on the patient chart he'd been reviewing. Pham, she said, Bay 1's potassium replacement should complete in the next 20 minutes. Recheck labs at 5 and let me know if it's still low. Got it, he said. She set down the chart. She looked at Holloway. at the woman with the tablet, at Lang, standing one step behind them with his hands at his sides, and the expression of someone who has recently been in a room where things were said about him that he could not dispute. "Lead the way," she said. She followed Holloway through the double doors and into the administrative corridor. And she was 3 steps past the threshold when the woman with the tablet turned and said something that stopped her mid-stride. "Ms. Carter, before we go in, I should introduce myself. I'm Dr. Patricia So, chair of the Medical Executive Committee." She said it with the careful, measured quality of someone who is choosing the order of information deliberately. "The board convened an emergency session 90 minutes ago. We've been reviewing the incident documentation from today's event, along with," she glanced at the tablet, "certain other personnel records that have recently come to our attention." Olivia looked at her. "We want to offer you the opportunity to respond," So said, "before any formal determinations are made. About today, and about several matters that preceded today." "What kind of determinations?" Olivia said. Zoe looked at her steadily. "That's what we'd like to discuss." A pause. "Both the ones in your favor and the ones that are not." Olivia went very still, not with fear, with the specific quality of attention that she brought to moments when the full shape of something was not yet visible but was becoming clearer by the second. "What does 'not in my favor' mean?" she said. Zoe glanced at Holloway, then back. During the review of today's incident, the committee identified documentation related to a patient outcome from 3 months ago, So said. "A patient in Bay 4, Mr. Delaney." The name hit her like cold water. Bay 4, the patient she had flagged this morning. The low-grade fever, the climbing white count, the infection referral she had put in before the mass casualty alert had overtaken everything. 3 months ago. She ran the timeline backward with the precise, rapid movement of a mind that was very good at processing information it didn't want. "The documentation indicates," So said carefully, "that a nursing observation flag was submitted in October regarding Mr. Delaney's initial presentation. The flag was not acted upon. The patient subsequently developed a septic complication that required extended hospitalization." She met Olivia's eyes. "The question the committee wants to examine is what happened to that flag after it was submitted." What happened to it? Olivia knew what had happened to it. She had submitted it, and it had entered the system, and then, as best she could determine, it had been reviewed by the attending and set aside, not maliciously, probably, just the normal institutional failure of a system where nursing observations were filtered through multiple layers before reaching the people who needed to act on them, and where the people at the top of those layers were sometimes more focused on surgical outcomes than on the upstream flags that could have prevented complications. She also knew that when the committee looked at who the attending physician had been for Mr. Delaney in October, they were going to find Victor Lang's name. She looked at Lang, standing 6 feet away with an expression that had gone very controlled, the expression of a man who had just understood what the next 15 minutes of his life were going to contain. He met her eyes. And for the first time in 7 months, it was Victor Lang who looked away first. The conference room on the 4th floor of Silver Ridge's administrative wing was not designed for the kind of meeting it was about to host. It had 6 chairs, a whiteboard with someone's half-erased budget projections still on it, and fluorescent lighting that made everyone look slightly worse than they actually were. Holloway had clearly grabbed the nearest available space rather than staging anything, which told Olivia that the urgency was real, that this had not been planned with any ceremony in mind. She sat across from Dr. So. Holloway took the chair at the head of the table. Lang sat to Holloway's right, a position that was technically neutral and practically exposed, the kind of seat you end up in when the room's geometry has already made a decision about you. Nobody offered water. Nobody made small talk. The tablet in So's hands was already open to whatever documentation the committee had assembled in its 90-minute emergency session, and Olivia could see from the angle that there was more of it than she had anticipated. "I want to be clear about the process here," So said. "This is not a disciplinary hearing. It's a preliminary fact-finding conversation. Nothing said in this room constitutes a formal finding or a binding determination." "Understood," Olivia said. "The committee is examining 3 separate matters simultaneously." Soe set the tablet flat on the table. The first is the clinical events of today, the mass casualty response, and the specific interventions that occurred. The second is the HR documentation filed this morning by Dr. Lang. She said his name without looking at him. The third is the October flag submission regarding Mr. Delaney's care and the question of what institutional response followed it. Lang shifted in his chair. It was a small movement. Olivia noticed it. I'd like to start with October, So said, because that timeline predates everything else. Ms. Carter, walk me through what you observed and what you submitted. Olivia did. She told it the way she told everything, directly, in chronological order without editorializing. The presentation pattern she had observed in Mr. Delaney over a 3-day period in October, the low-grade fever progression, the white count that was technically within range but trending in a direction she found concerning, the nursing observation flag she had submitted through the electronic system on a Thursday afternoon, noting her clinical concerns and recommending an infectious disease consult. And after you submitted the flag, So said, I received an automatic system acknowledgement that it had been received. I didn't receive any follow-up communication about the clinical decision. She paused. 3 days later, Mr. Delaney was transferred to the ICU with septic shock. So he made a note. The system shows the flag was reviewed and closed the same day you submitted it. Closed with a notation of reviewed, no action indicated. The reviewing physician was Dr. Lang. The room was very quiet. Holloway was looking at his hands. Lang was looking at the whiteboard, at the half-erased budget projections, as if they contained something interesting. Dr. Lang, So said, do you have a recollection of reviewing this flag? Lang's jaw moved slightly before he spoke. I review a significant volume of nursing flags. I don't have a specific recollection of this one. The documentation indicates the review took 4 minutes, So said, from the timestamp of opening to the timestamp of closure. 4 minutes. 4 minutes. For a flag that had laid out a 3-day trending pattern with specific vital sign data and a clinical recommendation. I made a judgment call, Lang said. At the time, the data didn't reach the threshold for intervention in my assessment. The patient developed gram-negative bacteremia, So said. He was in the ICU for 11 days. He lost partial hearing in his left ear as a result of the septic complications. Partial hearing. Olivia had not known that. She had known the sepsis, had known the ICU admission, had pieced together that something had happened from the fragments of information that filtered down through the institutional channels that nursing staff were not always fully included in. She had not known about the hearing. She kept her expression steady. Steady was not the same as unmoved. I want to be clear, Lang said. The flag was reviewed. A clinical decision was made. Whether that decision was optimal in retrospect, 4 minutes, So said again. Not loudly, just precisely. Lang stopped. The committee, So said, shifting her posture slightly, has also reviewed the nursing documentation from Mr. Delaney's admission today. The flag Ms. Carter submitted this morning before the mass casualty event overtook the department's attention. That flag identified the same pattern of infection indicators that she flagged in October. It was submitted at approximately 7:20 a.m. Yes, Olivia said. The difference, So said, is that today's flag was acted on. An infectious disease consult was ordered at 1:15 p.m., following a physician review that was prompted by the flag. She looked at Lang. A different physician this afternoon. Not Dr. Lang. Lang said nothing. Holloway cleared his throat. It was the sound of a man who had entered this meeting thinking it was going to be complicated and was now discovering it was going to be significantly more complicated than that. I think what the committee is trying to establish is whether the October event represents an isolated lapse in the flag review process, or whether it's indicative of a broader pattern. It's indicative of a broader pattern, Olivia said. Everyone looked at her. She had said it without particular heat, just the flat delivery of someone stating a thing they know to be true. Do you want to elaborate on that? So said. Over the 7 months I've been at Silver Ridge, I've submitted 43 nursing observation flags. 31 of those have been reviewed and closed without action in under 10 minutes. Of the 12 that did receive substantive responses, 7 came from attending physicians other than Dr. Lang. 5 came from Dr. Lang, all in the first 6 weeks of my employment. She had the numbers because she had tracked them, not strategically, not in anticipation of this moment, but because she was the kind of person who tracked things, and the tracking was simply how she understood patterns. The flags that received responses in under 10 minutes. In 3 cases, the patient subsequently developed complications that required escalated intervention. The silence that followed this was the specific silence of a room in which a number of calculations were happening simultaneously. "You documented all of this," So said. "I document everything," Olivia said. Holloway looked at Lang. Lang was no longer looking at the whiteboard. He was looking at the table, and the quality of his expression had changed. The layers of professional composure that had carried him through the first portion of this conversation were showing stress fractures, the particular look of a man who has entered a room with a story about himself and is watching that story come apart in real time. "Victor," Holloway said quietly. Lang looked up. "Is there anything you want to add at this point?" Holloway said. Lang was silent for a long moment. In that silence, Olivia watched something happen that she had not expected to watch. Not a breakdown, nothing dramatic, but the slow, visible exhaustion of someone who has been maintaining a position that required a great deal of energy to hold, and who has finally run out of the energy to hold it. "I dismissed her," Lang said. His voice had dropped. "Consistently. From the beginning. I made assessments about what she was capable of based on her title, and I didn't revise those assessments when the evidence indicated I should have." He exhaled slowly. "That's the truth of it." Nobody spoke. "The flag in October," he said. "I don't remember the specific clinical reasoning I applied. I remember thinking that nursing flags on stable patients were often overcautious. That was the framework I was working from." He paused. "That framework was wrong." Soe was writing. Holloway had the expression of someone who has received a confession they were not sure they were prepared to receive. Olivia sat with this for a moment. The admission was real. She could tell the difference between a strategic concession made to improve a position and an actual reckoning, and this had the texture of the latter, unwilling, uncomfortable, and therefore credible. It did not undo 11 days in the ICU. It did not restore the partial hearing. But it was real, and she acknowledged it as such in the only way that made sense to her, which was to continue being factual. "The pattern in the flag reviews," she said, "isn't only about me. I want to be clear about that. Other nursing staff have submitted flags that followed the same trajectory. Margaret Osei has data on at least 6 cases from the past 18 months that she's been tracking separately from me. We didn't coordinate it. We were both just paying attention." Soe looked at her. "Margaret Osei has been tracking this as well?" "Ask her," Olivia said. "She's better at the administrative documentation than I am." It was at this point that the meeting changed shape. The conversation that had started as a fact-finding session about Olivia Carter became, by slow and inexorable degrees, a fact-finding session about something considerably larger. So I asked 2 questions and made 4 notes, and then excused herself for 11 minutes. And when she came back, she had a different quality of attention. Not hostile, not alarmed exactly, but the focused seriousness of someone whose job has just expanded. The next hour was not comfortable for anyone in the room. Holloway asked for the complete documentation on the flag review pattern. So we brought in another committee member via phone, a Dr. Rourke, patient safety chair, whose voice through the speaker had the terse efficiency of someone being pulled out of something else and adjusting rapidly. Lang answered questions with the diminished, controlled precision of someone who understood that the ground beneath his position was no longer stable and who was trying to determine how to move without making it worse. Olivia answered her own questions with the same directness she had maintained throughout. She was not performing anything. She was not managing a narrative. She was simply doing what she always did, which was provide accurate information to people who needed it to make decisions. At 4:51, Holloway called the formal portion of the conversation to a close. He thanked Olivia and told her the committee would be in contact within 48 hours with a summary of findings. He looked at Lang and said, with the careful phrasing of someone who had chosen each word in advance, that he would like Victor to be available for a follow-up meeting the following morning. Lang stood. He looked, for a moment, like he was going to say something to Olivia, not to Holloway, not to Zoe, but directly to her, as if the meeting had produced enough clarity that he knew which conversation actually needed to happen. But he didn't say it. He nodded once and walked out. She stayed in the conference room for 3 minutes after everyone else had left. Not because she needed the time to compose herself, but because she needed the quiet. The particular quality of institutional quiet that follows a difficult meeting. The fluorescent hum, the distant sound of the hospital floor 2 levels below, the half-erased budget projections on the whiteboard that no one had thought to clean off. She thought about the 5th patient in the cardiac ICU, about Dara, the wife with 2 small children who had driven 90 minutes not knowing if she still had a husband, about Mr. Delaney and the partial hearing he would carry for the rest of his life. She thought about the October flag and the 4-minute review and the 11 days in the ICU, and she let herself feel the weight of it properly, not the compressed, functional version she had been running on all day, but the full version, the one that included the specific frustration of having seen something, named it correctly, submitted it through the proper channels, and watched it disappear into a system that had decided she wasn't worth listening to. She let herself feel it, and then she stood up and walked out, because the feeling and the walking were not mutually exclusive, and there was still work to do. The trauma bay at 5:15 had the particular rhythm of late afternoon, shift change approaching, the day's acute events metabolizing into the sustained management work of evening, the staff moving with the slightly different gait of people running on their second or third wind. Dr. Pham had stayed past his hours, she noticed. He was at the Bay 1 nursing station reviewing the repeat lab she had asked him to watch, and when she appeared at his shoulder, he looked up with the expression of someone who had been doing something he wanted to report on. Potassium normalized, he said. Last draw was 3.8. BP holding at 96. They're moving him to step down at 6. Good, she said. The 5th patient, he started. I heard. Cardiac ICU. Cautiously optimistic. Dr. Marsh was saying that without the tamponade identification, he stopped himself. He'd been doing that all afternoon, she'd noticed, starting sentences about the day's events and catching them before they became something too direct. Learning, maybe, how to acknowledge things without making them performances. Is the family still here? She said, meaning Dara. Step-down family waiting area. She hasn't left. Olivia set down the patient file she'd been carrying and walked to the step-down family waiting area. It was a small room off the main corridor, 4 chairs, a table with old magazines on it, a window that faced the building's interior courtyard. Dara was in the chair farthest from the door. The 2 children were asleep against her, one on each side, with the complete boneless surrender of children who have been awake far too long in an environment they didn't understand. Dara looked up when Olivia entered. She had the face of someone who had been holding everything very tightly for a very long time and was beginning incrementally to release the tension. Not because the crisis was over, but because the sustained emergency was finally resolving into something navigable. They said surgery went well, Dara said. It did, Olivia said. She sat down across from her. He's in the cardiac ICU. They'll let you see him in the next few hours. He's going to need time. The recovery from what his body went through today is going to be significant, but the surgery addressed the source of the bleeding and his heart is pumping on its own. Dara's eyes filled. She didn't look away. He was dead, she said. They told me he was dead when they found him. His heart stopped, Olivia said. We brought it back. How? It was not a clinical question. It was the question of a person trying to understand a thing that had happened to the person most central to their life, trying to make it real and narratable and something she could carry without it breaking her. A lot of people worked very hard, Olivia said, and we found the right problem at the right time. Dara looked at her. The paramedics told me. About you. About what you did. Olivia didn't respond to that directly. Your husband's crew members are all stable, she said. All of them. That's not something that was certain this morning. I know, Dara said. Then quietly, thank you. Olivia sat with her for another 5 minutes. She didn't fill the silence with reassurances or medical details or anything that would require Dara to process more than she already had. She just sat there, which was sometimes the only thing that actually helped. She was back at the nursing station at 5:45 when Margaret appeared beside her with an expression that was unusual for Margaret, a kind of controlled alertness, something between concern and the energy of a person who has received information they need to pass on. "Holloway's office called down 20 minutes ago," Margaret said, keeping her voice low. "They asked for my documentation, the case tracking I've been doing." "I know," Olivia said. "I mentioned it in the meeting." Margaret looked at her. You told them about my records?" "I said you had data on the flag review pattern. I said they should ask you." She met Margaret's eyes. "You've been keeping those records for a reason. This was the reason." Margaret was quiet for a moment. The expression on her face was complicated. Relief, and apprehension, and something older than both of those. The particular feeling of someone who has been waiting a long time for a thing to matter and is not entirely sure what to do now that it does. "How long have you been tracking it?" Olivia asked. 14 months, Margaret said. "Since there was a patient, before you came, a woman in Bay 6. I flagged a medication concern, and it was closed in 8 minutes, and 2 days later she coded." She stopped. "She survived, but I started keeping records after that." 14 months of records. Quiet, careful, diligent documentation from a woman who had been at this institution for 11 years and who had learned, the way people learn things in institutions that run on hierarchy, that making noise through official channels had predictable consequences, and that the most sustainable way to protect patients was to accumulate the kind of evidence that could not be argued with. "Send them everything," Olivia said. "All of it." "What's going to happen?" Margaret said. Not anxiously, just asking. "I don't know exactly," Olivia said, "but something will." The something began taking shape at 7:10 that evening, when Holloway sent a formal written communication, say, not an email, an actual document, delivered by his assistant to the nursing station, informing Olivia that the Medical Executive Committee had voted to place Dr. Victor Lang on immediate administrative leave pending a full review of clinical oversight practices in the trauma department. The review would include an external audit of nursing flag documentation and physician response patterns over the preceding 24 months. Administrative leave. Immediate. Margaret read the document over Olivia's shoulder. Neither of them said anything for a moment. 14 months of records, Olivia said finally. "And you're 7, Margaret said. They stood there with the document between them, and the fluorescent lights of the nursing station hummed their steady hum, and somewhere 2 floors up in the cardiac ICU. A man's heart continued beating with the stubborn, improbable persistence of something that had been given a second chance it hadn't been expected to receive. Dr. Pham came to the end of the station, looked at both of their faces, and looked at the document. "What is that?" Olivia handed it to him. She watched him read it, watched the moment when he understood what he was reading. Not just the surface content, but the context of it. Everything that had built up to this single administrative document landing on a nursing station at 7:10 on a Tuesday evening. He looked up. His expression had the quality of a young physician who is revising several things he thought he understood about how institutions worked. "He's been doing this for," Pham started. 14 months documented, Margaret said. "Probably longer. And people noticed," Olivia said. "Noticing and being able to do something about it are different things." He was quiet with that. The evening shift continued, labs were checked, drainage outputs were recorded. The step-down patient from Bay 1 was successfully transferred. The surgical airway patient in Bay 3 was now awake, groggy, confused, in pain, but awake, tracking faces with his eyes and responding to his name with the effortful, slightly bewildered presence of someone emerging from a very dark place into a world that was still there waiting for them. Olivia was there when he woke up. She happened to be in the bay reviewing his vitals when his eyes opened and focused, and she stood where he could see her clearly and said his name in a level, calm voice and watched him orient, watched the specific, private miracle of a person returning to themselves. "Hey," he said. His voice was rough from the surgical airway. Where? Silver Ridge Medical Center, she said. Ravenport. You're safe. The surgery went well. He blinked. The others? All stable, she said. All of them. He closed his eyes for a moment. When he opened them again, they were clearer. I remember the aircraft. Don't try to reconstruct it tonight, she said. There'll be time for that later. Right now, you just have to be here. He looked at her. Who are you? Olivia Carter, she said. I'm your nurse. He absorbed this. Then, slowly, you're the one they're talking about. She looked at him. Who's talking? The paramedics, he said. When they brought me in, I heard them before I... He paused. Before I went under. They were saying... He didn't finish the sentence, but something in his face completed it. The particular expression of someone who has been told, in the fragmented way you receive information on the edge of consciousness, that they almost didn't make it, and that the reason they did is standing in front of them in scrubs. Rest, she said. She adjusted his pillow 2 degrees. She noted the improvement in his color, the stronger quality of his pulse, the return of presence in his eyes. She made the notation in the chart and moved on. Because there were 4 other patients and 2 more hours left in the day, she had not planned to still be working. She was at the nursing station at 9:22, finalizing handoff documentation for the night shift, when her phone, her personal phone, not the work line, received a message from an unfamiliar number that resolved, when she opened it, into Admiral Grant's direct contact. The message had no preamble. It was 4 lines. Board of Inquiry final report published tonight. Harmon's reduction in grade is effective immediately and a matter of public record within the armed forces. Your service record has been officially corrected and restored. The offer on page 4 remains open. Olivia read it twice, the same way she had read page 3, not because she didn't understand it, but because she needed the second pass to let the weight of it settle into its proper place. Her service record restored, officially corrected. The falsified documentation that had ended her military career replaced with the truth of what she had actually done and who she had actually been, written back into the institutional record where it belonged. She set the phone face down on the desk and completed the handoff documentation. Checked it once, signed off. She was pulling on her jacket in the staff locker room at 9:40 when Margaret appeared in the doorway with a different quality of expression from anything she had worn all day. Something lighter. Something that had permission in it. Lang cleared his office, Margaret said. He came in at 8 and took his personal items. Security was with him. She paused. I didn't think it would happen this fast. Neither did I, Olivia said. Are you okay? Olivia considered this. She was tired in the specific deep tissue way of someone who had been running on trained discipline for 14 hours straight and was finally allowing the body to register its own reality. Her right shoulder was carrying a tension that would require attention. She had not eaten a full meal since the granola bar at 9:40 in the morning. I'm okay, she said. And then, because Margaret deserved more than the minimal version, it's a lot to process. You saved 5 lives today, Margaret said. We saved 5 lives, Olivia said. You've been protecting patients for 14 months with nothing but a spreadsheet, and the hope that it would eventually matter. That's not nothing, Margaret. Margaret was quiet. Then, in a voice that was careful and slightly rough around the edges, what are you going to do? After all this settles? Olivia picked up her bag. She thought about the document in her apartment, specifically about page 4, which she had read twice and not decided about. The reinstatement offer, the return to a version of herself she had laid down deliberately and that was now being handed back. She thought about the surgical airway patient asking who she was, about the flatness of his voice when he said, "You're the one they're talking about," and the way she had felt no need to clarify or confirm or expand on it. About Mr. Delaney's flag submitted correctly through proper channels and closed in 4 minutes and the partial hearing that followed. About what it meant to be good at something and invisible in the same moment, and whether those 2 things had to be true simultaneously, and what a person was supposed to do when the institution around them finally started paying attention. I don't know yet, she said. It was the truest answer she had. She walked out into the corridor. She was 3 steps from the exit when Holloway appeared from the direction of the administrative wing, Not the rushed, crisis-managing Holloway of the afternoon, but a more deliberate version, the version that had made a decision and was carrying it carefully. "Ms. Carter," he said, "I'm glad I caught you before you left." She stopped. "The committee met again at 9 o'clock, he said. "In light of today's events and the documentation review that's been initiated, we've made a preliminary decision regarding your employment status." She looked at him. "Effective immediately," he said. "The preliminary HR documentation filed this morning has been formally withdrawn from your personnel record. No copy will be retained." He paused. "Additionally, the committee would like to discuss, at your earliest availability, a formal expansion of your clinical authority and a role in the department's patient safety review process." She absorbed this. "And Dr. Lang?" Holloway's expression did the thing it had been doing all day. The careful, deliberate navigation of institutional language around a reality that was considerably less tidy than institutional language preferred. "Dr. Lang's administrative leave will remain in effect until the external audit is complete. At that point, the committee will make a determination regarding his position." He looked at her steadily. "I want you to know that what you and Margaret Osai brought to the committee today represents exactly the kind of patient safety infrastructure that should have been operating at this institution for the past several years. The fact that it wasn't, that's something we need to own." She said nothing for a moment. "I appreciate that," she said. It was not effusive. It was not grateful in the way institutions sometimes wanted gratitude to be, large and warm and easily filed under resolved. It was just accurate. She appreciated it. "Good night, Ms. Carter," he said. "Good night," she said. She pushed through the hospital's exit doors into the night air of Ravenport, cool, carrying the particular quality of a city after rain, the smell of wet pavement and something green from the trees that lined the parking structure. She stood on the pavement for a moment and breathed it in. Her phone was in her jacket pocket. On it, a message from Admiral Grant with 4 lines about a restored service record and an open offer. She had not yet replied. She was thinking about what she would say, about what she wanted, which was not as simple as it should have been, when she heard footsteps behind her and turned and found Dr. Pham standing at the hospital exit with his bag over his shoulder and the expression of someone who had come after her deliberately but was not entirely sure what to say now that he'd caught up. "I wanted to," he started. "You don't have to," she said. "I know." He shifted his bag. "I almost didn't do the decompression. This morning, I almost said, 'Let me get an attending,' which would have been, 'But you didn't,' she said. "Because you were certain," he said. "And I couldn't explain the certainty, but I could feel that it was real. That's not something they teach you." He paused. "Where do you learn that?" She looked at him for a moment. At the young physician who had made the right call this morning and was trying to understand the architecture of why. "You're already learning it," she said. "You just don't recognize it yet because it doesn't feel like knowledge. It feels like doubt with the wrong answer removed." He thought about this. "Go home, Dr. Pham," she said. Not unkindly, "You did good work today." He nodded. He turned back toward the parking structure. She was watching him go when her phone lit up with a notification. Not a message, but an alert from the hospital system that she was still logged into from the clinical side. A flag alert. Patient in Bay 4. Mr. Delaney. The infectious disease consult that had been ordered that afternoon had returned preliminary culture results, and they were exactly what she had suspected in October: gram-negative bacteremia, early stage, fully treatable if caught now. Caught now. 7 months ago, the same pattern. 4-minute review. 11 days in the ICU. Partial hearing. Tonight, caught. The flag she had submitted at 7:20 that morning before the mass casualty alert, before the military convoy, before the conference room and the administrative leave and all the rest of it. That flag, the one she had put in as a matter of course because it was what she did and who she was, had moved through the system today and reached a physician who had looked at it properly, and now Mr. Delaney was going to get the antibiotic protocol he needed in time for it to actually work. She stared at the alert for a long moment. Then she pocketed her phone and started walking to her car. She was halfway across the parking lot when the alert came. Not from her phone, but from inside the hospital, the specific sound of a rapid response announcement through the building's external speaker system that was loud enough to reach the parking lot in the night air. Rapid response. Bay 4. She stopped walking. Mr. Delaney. Her body had already turned before her mind caught up with the decision, already moving back toward the hospital entrance, already calculating the culture results, the early bacteremia, the gap between identification and treatment, whether the antibiotic protocol had been initiated yet, or whether there was a window in which something had gone wrong in that gap, whether she was about to walk back into a situation she had seen coming since 7:20 that morning, with the cold, specific weight of someone watching an almost preventable thing unfold in real time. The hospital doors slid open, and inside, the rapid response team was already running. She hit the doors at a run. Not the full sprint of panic, the controlled, purposeful acceleration of someone who has entered emergencies enough times to know that panic costs you the first 30 seconds, and you cannot afford to lose the first 30 seconds. She was through the entrance and into the corridor before the doors had finished sliding open, and she could hear the rapid response team ahead of her, the clipped voices and the wheeled equipment, and the specific quality of organized urgency that distinguished a functional team from a frightened one. Bay 4 was 40 feet from the entrance. She covered it in 8 seconds. Mr. Delaney was conscious. That was the first thing she registered. He was awake, which meant this was not a full arrest, which changed the calculus significantly. He was diaphoretic, pale with the gray-white quality of someone whose blood pressure had dropped, and his breathing had the shallow, effortful character of a body working hard to compensate for something the monitors were already showing. Pressure of 78/40, heart rate of 122, oxygen saturation dropping through 91. The rapid response resident, a woman named Doctor. Obi, who Olivia had worked alongside twice before and found competent and unflappable, was already at the bedside reading the monitors. Septic shock progression, Olivia said, arriving at the opposite side of the bed. The culture results came back an hour ago. Gram-negative bacteremia. Has he received any antibiotics yet? Obi looked at her. You're not... Has he received antibiotics? Olivia said. Same tone, no sharper, no louder. No. The order was placed, but the pharmacy hadn't pulled the emergency antibiotic stock from the Pyxis. Piperacillin tazobactam, empiric dosing, now, and 2 large bore IVs if he only has one. She was already at the supply cabinet. He needs fluid resuscitation concurrent with the antibiotics. 30 milliliters per kilogram, run it wide open first liter. Obi looked at her for exactly 1 second. The second of a physician determining whether the person speaking to them has the authority and the knowledge to be listened to. And then she turned to the nurse behind her and said, "Get the Pyxis open, Piptazo, empiric dose, and call pharmacy to expedite." She turned back to Olivia. "Walk me through his presentation." Olivia walked her through it. Not the history. Obi could read the chart for the history, but the pattern, the 7-month arc of observation that had led to this specific moment, the flag in October and the flag this morning, and the culture results that had come back an hour ago, and the gap between identification and treatment in which, apparently, Mr. Delaney's body had made its own impatient decision. Obi listened with the quality of someone absorbing information quickly and integrating it into action without pausing to editorialize. This was, Olivia had always thought, the most useful quality a physician could have in a crisis. Not brilliance, not authority, but the ability to take in new information and update in real time without ego getting in the way. "You've been tracking this patient since October," Obi said. It was not an accusation. "Yes." "And today's flag? You submitted it before the mass casualty event. 7:20 a.m. Obi looked at the monitors, at the blood pressure climbing in small increments as the first liter of saline ran in. "He's going to be okay," she said. It was not a reassurance. It was a clinical assessment delivered directly. "The bacteremia is early stage. We caught it before it hit the organs hard. Another few hours." She stopped. The implication was clear. Another few hours and the outcome would have been different. Another few hours and this would not have been a rapid response. It would have been something worse. The antibiotics arrived. Olivia checked the dose, the concentration, the rate, and stepped back to let the nurse hang the bag. Her role here was finished. Obi had the situation, the team was functioning, Mr. Delaney's blood pressure was already responding to the fluids, and would respond further to the antibiotics once they reached therapeutic levels. She stayed for 8 more minutes, not because she was needed, because he was her patient, and she had been waiting since October to be in a room where the right thing was happening to him in time. When his pressure hit 86 systolic, and his color began the slow return to something closer to normal, she picked up her bag from where she'd dropped it at the bay entrance. "Carter," Obi said. She turned. "That flag in October," Obi said. "If it had been reviewed properly, he wouldn't have lost the hearing," Olivia said. "No." Obi absorbed this with the expression of a physician who is 29 years old and has just received information about what the institution she works in did to a patient and is deciding what to do with that information. "I'm going to document tonight's event in full," she said, "including the timeline from culture result to antibiotic administration and the reason for the gap." "Good," Olivia said. She walked out of Bay 4 for the last time. The corridor was quiet at 10:20 in the evening, the particular quiet of a hospital at night. Not empty, never empty, but operating at a different frequency, the daytime intensity compressed into the watchful, steady focus of the people who worked when everyone else was asleep. She walked through it and out through the main entrance and back across the parking lot, and this time nothing called her back. She sat in her car for a few minutes without starting it. The rain had come back, light and steady, the kind that didn't demand anything from you, just existed on the windshield in slow, irregular patterns. She took her phone out and opened Admiral Grant's message. Read the 4 lines again. Then she opened a reply and typed 3 words and sent it before she could complicate the decision with further thinking. "I'll call tomorrow." Not yes, not no, but not silence either, which was its own kind of answer. She drove home. The formal board review was announced 6 days later. It was not quiet. Institutional reviews of this kind rarely were, but this one had particular visibility because of the mass casualty event that had preceded it. The military aircraft crash had generated significant regional coverage, and the story of what had happened inside Silver Ridge Medical Center on that Tuesday had circulated through the Ravenport medical community with the speed of information that people find genuinely surprising. The combination of a military convoy arriving in an ER, a rear admiral walking past a chief of trauma surgery to greet a floor nurse by a rank no one had known she held, and the subsequent administrative leave of that same chief of trauma surgery had produced a narrative that was hard to contain and that most people at Silver Ridge had stopped trying to contain. The review's formal scope was announced in a memo distributed to all clinical staff. An external audit of nursing observation flag review practices in the trauma department over the preceding 24 months, with particular attention to response time, clinical outcome correlation, and evidence of systematic pattern in non-response. 24 months of data. Margaret's 14, Olivia's 7. The 3 cases that had been identified where delayed or dismissed flags had preceded patient complications. The documentation was extensive and specific and did not leave much room for interpretation. Victor Lang's administrative leave was extended through the duration of the audit. On the 8th day following the crash, the Medical Executive Committee released a preliminary findings statement. Olivia read it at the nursing station during a quiet moment between patient checks. It was written in this compressed, careful language of institutional accountability, measured, precise, and considerably more direct than such statements usually were. The committee had found evidence of a systematic pattern of inadequate review of nursing observation flags in the trauma department over at least the past. The chart hit the floor before she could react. Dr. Victor Lang had swept it from her hands without breaking stride, without looking at her, without a single word of acknowledgement, just a casual, contemptuous flick of his wrist that sent blood-soaked trauma papers scattering across the polished linoleum of Silver Ridge Medical Center's trauma bay. Olivia Carter knelt and picked them up. Every page. Every one. Nobody helped her. Nobody even glanced her way. To the surgeons, the residents, the charge nurses running past, she was furniture. Background noise and scrubs. Not one of them knew what she had once commanded. Not one of them knew what was already coming toward this hospital at 200 miles an hour. They were about to find out. If this story already has you hooked, stay with me until the very end. Hit subscribe so you never miss what happens next. Leave a like if Olivia deserves justice, and drop a comment telling me what city you're watching from. I want to see exactly how far this story travels. The morning had started like every other morning at Silver Ridge. Olivia arrived at 6:45, 20 minutes before her shift technically began, because that was just how she was built. She checked the overnight board, reviewed the handoff notes from the night team, and quietly flagged 2 patients in Bay 4 and Bay 7 whose vitals had drifted in directions that nobody else had flagged yet. She left notes in both charts. She didn't make an announcement about it. She just did it and moved on. Bay 4's patient was running a low-grade fever that had ticked up 0.2 of a degree over 3 hours. Nothing that would trigger an automatic alert, but enough of a pattern that Olivia had learned in a different life, in a very different kind of operating environment, to pay attention to. Bay 7's patient had a subtle asymmetry in bilateral breath sounds that the night nurse had attributed to positioning. Olivia wasn't convinced. She flagged both. She moved on. By 7:15, the day shift was in full swing, and Dr. Victor Lang had already made his entrance. There was no other word for what Victor Lang did when he walked into a room. He didn't arrive. He didn't show up. He made an entrance, shoulders back, chin elevated at a precise angle that communicated both authority and barely concealed boredom, the white coat immaculate, the stethoscope positioned with the studied casualness of someone who had practiced studied casualness for many years. He was 47 years old, the chief of trauma surgery at Silver Ridge Medical Center, and he moved through the hospital as though the building had been constructed specifically to serve as a backdrop for him. Morning rounds, he announced to no one and everyone, and the cluster of residents who had been waiting near the nursing station immediately fell into formation behind him, like ducks behind a particularly aggressive parent. Olivia was standing at the medication cart when he swept past. She had the blood work results for Bay 4's patient in her hand. The fever had confirmed her suspicion, white count climbing, early signs of a brewing infection that needed intervention now before it escalated, and she stepped forward. Dr. Lang, I need to flag something on Mr. Delaney in Bay 4. His labs came back and I think... He took the chart from her hand without slowing down, glanced at the top line. Then, with the same thoughtless efficiency with which someone might discard a piece of junk mail, he swept his arm to the side and let the papers go. They hit the floor in a cascade of white, some of them sliding 6 feet across the linoleum. Have housekeeping clean that up, he said, to no one in particular. To one of his residents, without pausing, I want updated imaging on the post-op in Bay 2 before I get there. And he was gone. Down the corridor, residents trailing behind him. The mild ripple of the moment already smoothed over, as if it hadn't happened at all. Olivia stood very still for exactly 2 seconds. Then she bent down and picked up every page. Margaret Osei, one of the senior nurses who had been at Silver Ridge for 11 years, appeared at her elbow and helped gather the last few sheets without comment. When Olivia straightened, Margaret's expression was carefully neutral, in the way that people's expressions become carefully neutral when they have watched the same scene play out enough times that outrage has curdled into something quieter and sadder. Chart audit this afternoon, Margaret said quietly. Lang wants all nursing documentation reviewed for the Caldwell complaint. I know. Olivia reorganized the papers. Bay 4's patient needs an infectious disease consult today. I'm going to put in the referral. Lang didn't... I know. She met Margaret's eyes for a moment. I'll document it properly. He can countermand it if he disagrees. She said it without heat. She turned back to the medication cart and continued what she'd been doing. Margaret watched her for a moment, then went back to her station. This was the texture of Olivia Carter's days at Silver Ridge Medical Center. Not dramatic, not cinematic, just a continuous grinding accumulation of small dismissals, each one individually unremarkable, collectively exhausting. She had been working at Silver Ridge for 7 months. She was 31 years old. She held a master's degree in nursing with a specialization in critical care, and she had arrived with a resume that listed 8 years of clinical experience, which was technically true, and which told approximately 3% of the actual story of who she was and what she had done. She had not filled in the rest. This had been a deliberate choice. People tended to react in complicated ways when they learned the rest. Some became deferential in ways that made her uncomfortable. Some became suspicious or competitive, or challenged her constantly, as if she had something to prove. She had come to Silver Ridge wanting to be a nurse. She had wanted the work without the history attached to it. She had wanted to stand in a trauma bay and help people without the weight of a different identity reshaping every interaction. She had not anticipated Dr. Victor Lang. Or more accurately, she had not anticipated quite this particular variety of institutional hostility, the kind so embedded in the hierarchy that most of the people around her had stopped seeing it at all. The morning progressed. She completed her medication rounds, assisted with a difficult IV placement that 2 other nurses had already attempted, sat with a post-surgical patient whose anxiety was spiking and talked him back down from the edge of a panic attack with the particular kind of low-key, matter-of-fact calm that she had developed in environments where panic costs lives. She ate half a granola bar standing at the nursing station at 9:40 because she hadn't had time to sit. She flagged a potential drug interaction that the attending physician had missed and sent a quiet message through the system rather than making an announcement. She was good at this. She had always been good at this. And at Silver Ridge Medical Center, being good at this and being invisible were apparently not mutually exclusive. At 10:15, the emergency alert system activated. Not the standard alert that indicated an incoming trauma or code blue. The mass casualty protocol. A sound that most of the staff at Silver Ridge had never heard activated in a real emergency, because the last time it had gone off for real was 4 years ago. A multi-vehicle accident on the highway that had sent 11 people through their doors simultaneously. What came across the radio from dispatch was clipped, professional, and hit Olivia in the chest like a physical impact. Silver Ridge Medical, this is Ravenport Emergency Coordination. We have a military aircraft down. Repeat, military aircraft down, approximately 11 miles north-northeast of the city. Initial reports indicate experimental test aircraft with crew of 5. Multiple critical casualties confirmed. Ground transport en route, ETA 18 to 22 minutes, requesting full trauma activation. The trauma bay erupted. Victor Lang's voice cut through the noise immediately, loud and commanding, already stepping into the role that crisis gave him. The role where he was most comfortable, where the authority was absolute and unquestioned, and even people who privately disliked him acknowledged that he performed well. He was not, in fairness, a bad surgeon. He was a skilled trauma surgeon with a genuine talent for operating under pressure, for making fast decisions and executing them cleanly. His problem was not competence. His problem was that his competence had insulated him from ever having to grapple with what lay beyond it. Full trauma team to Bay 1, 2, and 3. I want the OR on standby. Respiratory, get your team down here. I want blood products, O negative, staged in the trauma bays before they arrive. Go. People moved. Olivia moved with them. She was already running the math. 5 crew members. Military test aircraft. The language in the dispatch, experimental, meant unknown specifications, potential for unusual injury patterns, possible exposure to fuel types or materials not standard in commercial aviation. Crash at speed. Blunt thoracic trauma was almost guaranteed. Traumatic brain injury possible in multiple casualties. Extremity injuries, probable burn component if there was post-crash fire. She went to the supply room and pulled things that hadn't been requested yet. A needle decompression kit, chest tube trays, an emergency surgical airway kit. She set them on the crash cart in trauma bay too, with the efficient, economical movements of someone who had done this kind of preparation in conditions considerably less favorable than a fully equipped American hospital. Margaret appeared at her elbow again, eyes wide. Lang hasn't called for those yet. I know, Olivia said. He will. She had the airway kit open and staged before Lang had finished his second round of orders across the trauma bay. She did not draw attention to it. She positioned it where it would be immediately accessible and went to take her assigned position on the team. The 18 minutes before the first ambulance arrived had a specific quality that Olivia recognized. The tight, breathless preparation of a unit about to receive incoming, the controlled chaos of people making final checks, the adrenaline that had to be managed rather than suppressed, because suppressing it entirely made you slow. She had stood in this same interior space more times than she could count, in operating theaters that had been tents, in surgical suites that had been the back of armored vehicles, in field hospitals where the equipment she had staged was not silver crash carts, but battered field kits held together with tape and institutional stubbornness. She breathed. She checked. She waited. The first ambulance backed into the bay at 10:33. The paramedics were calling out stats before the doors opened. Male, approximately 35, blunt thoracic trauma, GCS 12 on scene, dropped to 9 in transport, BP 80 over palp, tachycardic at 128. The gurney came through the doors, and Olivia had already positioned herself at the patient's left side before the attending resident reached him. She didn't push anyone out of the way. She simply moved to where she needed to be with the kind of quiet authority that didn't require announcement. She looked at the patient, not at the monitors, not at the readouts the paramedics were relaying, at the patient. The trachea was deviating slightly to the right. The left chest wall moved differently from the right on each labored breath. Subtle, the kind of thing that monitors didn't catch and that exhausted eyes could miss entirely. His neck veins were distended despite the compromised blood pressure. Tension pneumothorax. Classic presentation, slightly atypical in degree, but unmistakable once you knew what you were seeing. He needs decompression now, she said. Left side, second intercostal, mid-clavicular. The tracheal deviation is right-sided, tension pneumo. He's going to arrest if we don't decompress. The resident, Dr. Pham, second